So first of all, I want to thank our panel here. The talks that we just heard were really phenomenal and covered a lot of the questions that people have sent in. And in addition to the panelists to the speakers that we just heard from, I also want to introduce and welcome Dr. Chandra Sen, who is the chairman of our medical advisory board and a member of our board of directors. And I think he's well known to many of the clival chordoma patients in the room. So the way we've done this is we've had you submit questions online via registration. The Facebook survivors group has collected a lot of great questions. A group of volunteers has then culled those questions and boiled them down to the ones that were most frequently asked. We also have a stack of questions that have been asked throughout the day. And I'm told that we have questions from YouTube as well. So I'm going to try to, we clearly have more questions that can be asked in this short amount of time. But I'm going to try to hit some of the high points and then leave about 15 or 20 minutes for some open Q&A. And if I could just remind everyone, when you have a question, to please come up to the microphones at the side of the room and make sure that we can all hear your question. And if you can't get up, if you'd like a mic to come to you, just raise your hand and Shannon will bring you a mobile mic. So I suppose we'll just dive right in. I think a question that's come up consistently over and over again is with respect to diagnosing chordoma. And maybe we can kind of progress from diagnosis through initial treatment, through recurrence and palliative care, et cetera. But in the case of diagnosis, for skull base, for spine, for sacral, what's the consensus, or is there a consensus about biopsy? Because we hear conflicting things. Some people say yes biopsy, no biopsy. What does the panel feel? And please feel free, anyone can jump in.
I'm very strongly in favor of biopsy because even though something looks like something very, I just do cancer, and I say every month something that looks typical, including last week. I had somebody who was sent from Michigan to have looked like, smelled like a chordoma, and they were going to just do a sacrectomy in Michigan, and it turned out it was metastatic renal cell carcinoma. I think you can never be criticized for doing a biopsy, but you certainly can be criticized for not doing a biopsy.
Yeah, I think we all know of situations where the initial treatment was very different because the physicians weren't aware that it was a chordoma. And I think that's one of the biggest problems is when people don't biopsy and they think it's a metastatic tumor or something else, and the appropriate treatment is not given for a chordoma. And a lot of that can be alleviated not only just of a strong clinical suspicion of a chordoma, but actually getting the biopsy before planning some kind of surgical intervention or any other intervention. And a lot of the problems with managing chordomas, I think, come from the fact that the initial treatment was not a chordoma treatment, and the biopsies will often, I think, help alleviate that. Because that's a big problem.
There's just one other thing, and I know people worry about it. Patients say to me all the time, is he going to disseminate it or spread it? That is absolutely not true. I deal with sarcomas in every part of the body, and you make more mistakes by not doing it. You have to know how to do a biopsy, and it should be done by somebody who knows what the next procedure is going to be. One of the problems with, certainly with sacral chordomas being biopsied, was that people many years ago used to do them through the rectum. And of course that contaminated the rectum and meant you had to have a colostomy if you really wanted. A lot of it comes from that. So I think it should be done carefully. Somebody who knows what they're going to do next time. I always tell the residents, you got to think of the next operation, or who's going to radiate or where. And I think it's the disadvantages, of which I don't think there's any, they certainly far outweigh the advantages far outweigh the disadvantages. But this idea of it disseminating it there's no basis for that I know of.
I think for the sacral chordoma, that applies. But for the skull base and cervical spine, I think it's a different story. Because imaging features of chordomas are very classic. And you can have an experienced neuroradiologist tell that on the basis of a scan. And getting to a biopsy for a skull-base lesion or a cervical spine tumor is not easy. And the risks involved in doing a biopsy of a clival tumor are just about close to doing the surgery itself. I have seen people coming with CSF leaks after a biopsy. I have seen non-diagnostic biopsies. So that doesn't help, and you went through that. Sacral tumors, I have completely no argument about that. Clival tumors, I think that, and what I tell my patients is that the signal characteristic is strong enough indicating that this is a chordoma that I would say it should be an excisional biopsy rather than a biopsy itself, because the entire procedure to remove it and do the biopsy is pretty much the same. The resection is, if you have a very good CT scan, very good MRI scan with all the sequences, I have not seen a big problem in misdiagnosing a chordoma into a metastatic disease or some other type of tumor. So I vote, and at least in my practice, that's what I recommend to them, that an excision with a goal of doing, because we are still in the sacral field, you can still do an en bloc resection. You can still do a gross total extracapsular resection. Whereas in the skull base and the cervical spine, even though some people have published on getting en bloc resections, even of the cervical spine, I personally disagree it's possible. You invariably get into the tumor. So since it's going to be a piecemeal tumor resection anyway, the goal of getting around the tumor is still the same. And that's what I suggest doing instead of going through a biopsy.
So one advantage of a biopsy is, I won't comment this from the surgical, I'm not a surgeon, so I'm not going to comment about the difficulty or the ease or the complications after biopsy. But what a biopsy, which is a very small amount of tissue that's taken out, is that it gives the pathologist to know, what are we dealing with? Is this truly a chordoma or is this something else that mimics a chordoma? That's question number one. The second part that the biopsy allows us to do is to do these genomic studies. You don't need a lot of tissue. You need a very, very, very tiny amount of tissue to do these studies. And with a very small amount of DNA, we can get an incredible amount of information very early on. And frankly, at every point throughout the care of the patient. And as I mentioned earlier, tumors, whether it's chordoma or is it any other cancer, is constantly changing and evolving. Okay, so it'll be equal to for me to tell you, there's a great company called Enron, and you guys should go and invest in it. Okay, right? So because that means I'm reading the newspaper from 2000. So and that's just you understand the ridiculousness of it. So throughout the course, if it is safe and if it's really the surgeon and the interventional radiologist have to make the decision about is it safe and feasible. If it is, I would personally think it gives you a lot more information than just is it chordoma or not, because at any point you can get that information about what are the switches that are currently turned on and off.
I was just going to add one more point. I think this will be a recurrent theme throughout the Q&A, that the anatomy for clival chordomas and sacral chordomas and mobile spine chordomas is very different, as are repercussions and surgical techniques. But one thing that our interventional radiologist tells us, and this is more related to spine and the sacrum, is that the biopsy techniques have changed as well, and the instruments that they use have changed. So we've all seen sacral chordoma or spinal chordoma picture where the needle tract has tumor going right along it, and it looks awful. But those are probably more older pictures that are not as relevant anymore, because the needles that they use are different, so less likely to see it. But at the same time, I think we have much more of an opportunity to excise it if needed, rather than a skull-based one.
That's great. So let's say we do get a biopsy, or we get tissue through a resection. What does one do with that? What are the important things to be testing for? and some things that people asked about brachyury. Should every tumor be tested for brachyury? What about proliferation index? Does that make a difference? These other genomic analyses that Dr. Gounder mentioned. So,
well, all of these, they will all have brachyury. Even the benign daughter-chordal tumors will be brachyury positive. Maybe Dr. Hamid is here, and she should be down here
please,
maybe to answer questions like that. The pathologist.
We have a chair for you, by the way.
Okay, so what should we do with the tissue that we receive? We have to first make a diagnosis, and we don't always need the brachyury to make the diagnosis. We've been making diagnosis of chordoma before brachyury came to the picture. When we receive very small biopsies, then we would think, okay, let's do the brachyury and confirm it. But when we have decent amount of tissue, we don't always need to do it. So it's not a must to do brachyury. For proliferation, it just so happens chordomas are not highly proliferative tumors. So even when we look at the cells, they're not in front of your eyes dividing. It's slowly growing. It takes probably 2 days before one cell divides to the next. So any kind of markers which will help in the proliferation are not very helpful to assess in this tumor. So that's not routinely done. So what else we can do? Whether now we are in the genomic era, and now we're trying to find out, are there signatures for these tumors that would help us differentiate one person's tumor from the other, or a sacral tumor, is it different from a clival tumor, or in the mobile spine? Those type of questions you can answer, perhaps by the genomic analysis. And that's where but we still don't know the signature, right? So you can't take one tumor and say, okay, let's just send it for what type of genomic analysis? Should we do the whole genome analysis, whole exome analysis? There's many, many different ways of doing it. So we have to first come up with signatures that we actually know, and then obviously the tumors will be sent, because that's going to tell you some information that will direct the treatment. We are not there yet. Of course, places like Memorial, we have opportunity to do some genomic analysis, and we try and do it. We do it, as Dr. Gounder was talking about. Yeah, there's funding for it. Every patient's tumor is sent for the genomic analysis, and we do that. Or I do research, so I take the tumors and study them and say, okay, can I find some signature that will help? So that's where the tissue is helpful to have, and perhaps in 5 years from now, we could be doing some kind of genomic analysis in every tumor.
Maybe I could ask the panel a question. Let's suppose the biopsy came back as a dedifferentiated chordoma.
Yes.
And it was relatively, is that would that make a difference on whether you might just observe the tumor, or would you want to recommend more active treatment? Let's say the patient's not symptomatic, but the biopsy comes back as dedifferentiated. Would that make a difference in what you want to do right away?
I think it's Dr. Gounder.
No, I have nothing. I can only make the diagnosis.
So, as I mentioned earlier, these old school chemotherapies don't really work in chordomas. But the exception is that it may have some role, it may have some activity in this dedifferentiated chordomas. Having said that, I still think if surgery or radiation is a possibility, it's better to opt for those, because even in dedifferentiated chordomas, the role of chemotherapy is just quite marginal. So in those patients, I think if there's an opportunity to resect or to do radiation, I would absolutely favor that, because those tumors are very high risk of recurring just locally as well as spreading elsewhere as well. So I think if there's a small window of opportunity to get rid of the problem, we should really go full force. And I give chemotherapy, but I'm not terribly enthusiastic about even in the DDIF.
What about one? Can I just one other thing on that though? The clival ones are very often different in that they're more chondroid. You get a chondroid which may have a better prognosis. rather than the common or the dedifferentiated. What would you say about that? I mean, that's one of the useful things to know, maybe, at least from a prognostic point of view, whether it's chondroid chordoma.
Yeah, I think the difficulty is, though, with a biopsy, how reliably can you really say it's a dedifferentiated chordoma? See, that's where the problem comes with the biopsy. The biopsy is differentiating between a chondrosarcoma and a chordoma, differentiating between a chondroid chordoma or a typical chordoma versus a dedifferentiated chordoma. It is not reliable. So I don't think you can really, at least in my experience, label your rest of the treatment based on that needle biopsy.
I mean, that's true, but I think that is one of the potential benefits of getting the biopsy, is that that's extra information. And, you know, obviously there are a lot of situations, you know, more of Dr. Sen's practice where biopsy is maybe not even advisable. But in situations where a biopsy is possible, I think that there are a lot of positives to getting the biopsy, and, you know, even being able to figure out, even if it doesn't look like a really, you might think looking at it or assessing the patient that maybe this is something you could observe. But if you knew that it was something more than just a classic chordoma, I mean, that could change your management from the get-go.
One other point, too, is if you're going to radiate, I mean, if you're going to take it out anyway, it's probably, you know, you probably don't need a biopsy up in that area. But if you're going to radiate it first, then you have a problem with, well, God forbid it was something you didn't, it was a chondrosarcoma, it's different. But the other thing is from culturing cells and doing your genomic analysis and all that, it's altered by your radiation therapy, and you don't have the fresh tissue. That's a relative problem that you have to take into consideration with the biopsy.
Chondroid chordomas will have brachyuria expression, whereas chondrosarcomas do not. So you could do that to differentiate both.
Josh, if I could just ask the panel one more question, and it'll be brief, to Dr. Sen and Dr. Boland. So as a sequel, do you ever make the decision to just observe something? When do you do that? When somebody's diagnosed newly with a chordoma?
I mean, from my practice is upper cervical and skull-based chordomas. There are situations in which I have observed patients, don't necessarily go into an operation. My first encounter with the patient always is if the imaging is strong enough and the tumor is small, then I think we have a window of observing. If the tumor is already big to start with and looks like a chordoma, I almost never advise observation, even if it's asymptomatic. I have picked up asymptomatic chordoma many times, and there is a window, I truly believe, a window of opportunity where it is not getting into the carotid, it's not getting into the vertebral arteries or something like that. You can get a very good resection. I have patients who I've monitored for 10, 15 years, free of disease. Why? Because it was picked up at that window of opportunity. If it is tiny, and it looks like a chordoma, patient is asymptomatic, found out because they hit their head somewhere, somebody did a CAT scan, and there it is. So we say we have to be vigilant. I monitor them. I tell the patient, education is the real important thing. And the education at the first encounter of a patient is very important. I really believe that's where you impact on the patient's life and decision process the most. And I really spend a lot of time doing that. But those are the only situations where I will observe. But I cannot speak on Dr. Boland's behalf.
Well, I agree. Sometimes I will watch. If I just operated on somebody this week who we weren't sure whether it was a true chordoma or a notochordal rest, an unusual notochordal rest, which is the benign variant, which probably wouldn't do any harm, But it was in an area, and we biopsied it, and Dr. Hamid couldn't even tell. So we had a dilemma. Now, it was below the level of serious function. In other words, in this situation, it took a low sacrectomy, a very low one, wasn't going to interfere with bowel, bladder, sexual function, or ambulation. I think that I took it out. If that had been high, say up at S1 or S2, where it would have big impact, like we were saying up at, same as would apply to the upper cervical spine, I probably in that situation would have observed that. I think every case is different. So I
great.
agree.
So
I agree with that visual.
now, we heard Dr. Yamada talk about how radiation alone can be so effective. Some patients get surgery alone, and the question, if they've had a complete resection, the question comes up, should they get radiation? What are people's thoughts about that?
I think that there probably are cases where there's no added benefit to radiation, but these have to be very small, early lesions where there's a high degree of confidence that the tumor can be removed en bloc. And we come across those lesions occasionally in the low sacrum, in the coccygeal area, for example, where the tumors are small enough, and Dr. Boland's going to get such a wide margin that I think the benefit of radiation is questionable. But outside of that kind of a scenario where we're very confident that we're going to get very good margins, I think that radiation therapy should be considered as part of the management of that tumor.
I think we'll never know the answer to that question until we do a controlled trial, and we'll never do a controlled trial on this because those that are convinced radiation therapy is right, and I've been trying to, extrapolating from soft tissue from sarcomas, there is an added benefit, a definite added benefit for local control with radiation therapy, no doubt. We extrapolate that to this rare tumor, chordoma, and I would do it now, but I've tried for years and years to see if we could get a trial where people would volunteer not to have radiation therapy and people would to have it. And it wasn't just the patients, it's the physicians. I mean, the people from the Massachusetts General Hospital believe 100% in radiation therapy. We were kind of in between. The Mayo Clinic at one time didn't really believe in it. And you couldn't get the people to do this study. And I think you agree. I don't think we'll ever, that's one of these many things in medicine we'll never do could never do a controlled trial on. But extrapolating from the other things, I think that a low one, small one, I think there's somebody here at the moment who doesn't have radiation therapy because I didn't send them to Josh. But I don't think he would have. It is a very small distal lesion. And you agree?
Yeah, I think talking about unblock and wide margin is really important, and knowing the difference when you talk about these things. So unblock is taking it out as a whole, and we think that doing that alone is not really good enough because this is a malignant tumor. We worry about spread of the tumor around. Having a wide margin is different because this way we actually have healthy tissue around it, and that makes it less likely to invade surrounding structures. So if somebody can have true wide margin resection, which is probably in the spine at least, mobile spine and the sacrum only possible in the sacrum in very select instances, I think most of the time we would recommend radiation in the mobile spine or the sacrum for that matter.
So I think a question that's probably on the minds of many in this room, since everyone here has already been through initial treatment, what should people, what are the factors that contribute to or that predispose to recurrence or metastasis? Are there key things that you could point out that might indicate a higher or lower risk of recurrence or metastasis?
There's no doubt. I mean, I review a lot of papers for publication, and there's one thing that comes through on all of them. You usually have to turn them down because there's nothing new in the paper. Is that small distal tumors, this is now down in the, I think small distal tumors in the sacrum certainly do very well, and so the size of the tumor, and in sarcomas generally, the bigger the tumor, the more likely you are to get recurrence. I think that when you get big ones, if you don't give radiation therapy, I do believe this, that they're more likely. But I think that the real basic answer, we don't know. like Dr. Gounder was saying, there's probably no two chordomas exactly the same. And there's something at a molecular level that if we knew, that's the answer to that question. Because you can get people, before they did radiation therapy, there were chordomas, not all chordomas that had positive margins recurred. Why was that? And then some that you did get negative margins recurred. There's something we don't know about, and that's kind of the basic answer to that. We just don't know enough yet. And, it's the molecular people is going to come up with that, hopefully.
I think from the radiation perspective, there's some interesting data to suggest that the quality of the radiation and the amount of radiation that's given is a prognostic factor for recurrence. There's a couple of papers from MGH where they did an analysis of local failures after treatment, and they found that 75%, well, this is both chordomas and chondrosarcomas, but 75% of those recurrences happened outside of the high-dose region. So it's either that the appropriate area was not given the high-dose radiation, or that it just happened to observe a recurrence outside of the area where the high dose was administered. And so we know that the dose of radiation can make a difference, and there's other data to suggest that going below 60 gray, for example, there's really not much benefit to the radiation. You have to go to higher doses than that. And so the quality of the radiation certainly can have an impact on at least the local control from a radiation perspective.
From the skull-based literature, we found, as we had also published, is that the control rate or recurrence is quite intimately related to the initial size of the tumor. And initial size of the tumor, I mean that the volume of the tumor mass itself, and also the areas that it is going into. Because these tumors will go into a variety of compartments in the cervical spine, in the lower spine, in the skull base. And whenever they go into these different compartments, it is very easy to miss a tumor compartment and leave something behind. And that's what most of the time leads to recurrences. So the literature strongly shows that the initial volume of the tumor, the compartments involved by the tumor, which all lead to an incomplete resection. And that is really the key factor that you all must remember. Whether you're dealing with an initial disease, virgin disease, or even a recurrent disease. Because even in a recurrent tumor, if you can still get the whole tumor, you're still better off than leaving it behind and then looking at other adjuvant measures. So quality of radiation for sure you can give, but the problem is your quality of radiation and the intensity of radiation is limited by the critical structures that are involved. So you can only radiate so much of the brainstem or so much of the certain cranial structures, or even the rectum, the bowels and the spinal cord. So many constraining factors. So the key is really the size of the tumor and the areas involved.
Thank you, Dr. Sen. A question that's come up frequently is about metastasis and how frequently it occurs. Does anyone have an estimate or a number?
What metastases?
How frequently metastasis occurs?
30%.
Well, the incidence of metastases overall in chordoma is 30%. They usually occur late. I saw one of the questions. The most common place for them to go to is the lung. It's usually very late, and it's associated again with the size of the tumor. The big tumors are more likely, and this is so with all sarcomas. But it's a late event. It's 30% is the figure. The lung is the most common. Next would be other bones. So you can get them in other bones as well. And you then probably lymph nodes are there. But their lymph nodes, I notice on one of the questions, do they travel by blood? They spread around the body primarily through the bloodstream rather than lymphatic stream, but they're some rare ones will get into the lymphatics. We had one, I shared one with Dr. Horncheck from Massachusetts General very recently that had, but that's kind of the exception.
You mentioned, yeah, you mentioned
20 years? Yeah.
We thought it meant late in life. So correcting.
No. It's usually a late event in the course of the disease. But I mean, obviously, it's 30%. That's the figure quoted.
So if there is a metastasis, what do you recommend? What can be done?
What do you recommend?
In the case of metastasis, what's the standard of care if there is a metastasis?
If you can take it out, there's one thing that's new that nobody mentioned today, that for small, I think, for small recurrences, generally, if you have local recurrences or distant recurrences, you try to take them out if you can, but the experience with that and the literature would indicate that it's not very good, but it's better than not doing it, and you can radiate it. But there's one other thing that I've started doing now here is if we pick up an early metastasis and try get the radiologist, interventional radiology, to either put a probe in and freeze the small piece and kill it, or do what they call radiofrequency ablation. We've only done it on a couple, but I think it might be something that could be done with early detection, that you wouldn't have to just observe it. You could do this quickly, whereas you might observe something and let it get bigger before you'd resect it. That's...
Are you talking specifically about chordomas, or are you...
I'm talking about chordomas that we've been doing it in other tumors. We've been doing, in other sarcomas, we've been doing radiofrequency ablation, but there's not a lot out there on it. I've just, borrowing from that experience, I've done a few cryoablations, in other words, freezing, but I don't know what's going to happen yet. This is very new.
Have you done this on chordomas, or are you talking...
Yes, on chordomas, yeah.
Dr.
And they're small.
Well, I think another important point in chordomas is that people can have multicentric chordomas. Like if you have a skull-based chordoma, there can be another chordoma in the sacral spine or something. So it's important that first time a diagnosis is made, they should have imaging of the entire spinal axis. So you are not, and I've seen this in my practice, people with multicentric chordomas. And as you know, the notochord, which is the origin of this tumor, goes all the way from the skull base to the tailbone. So there can be a simultaneous change, because what we think is happening is that something that was present in your fetal life is getting reactivated to produce this tumor in an adult life. It shouldn't be so, because the brachyury is shut off when you're even 10 weeks old. Something brings it up again to work again. And it can happen anywhere, not just in the clivus. It can happen in the cervical spine also. So this is another thing to remember, is when the patient is being monitored, you have to monitor with an entire axis imaging. And I think still for metastasis, if you can take it out, that's the best thing. And another thing I have observed is that in my series, that only I think 1 or 2 patients who have had metastases have had no local recurrence. So anybody who has a local recurrence is susceptible to a metastasis. And I think it is more common in sacral tumors because they are much larger when you pick them up compared to a clival tumor or a cervical spine tumor. That's been my experience.
We've actually developed a fair number of patients treating palliatively with focal radiation, with what's called stereotactic body radiotherapy or radiosurgery. And this is not just for chordomas, but there's a number of tumors, like a number of sarcomas, that we just don't have effective systemic therapy. And radiation therapy, in a sense, becomes the systemic therapy. And so whenever a patient pops up with a metastasis, then we can actually give most of those patients it's a relatively non-invasive way to treat those metastases and keep patients at a relatively high quality of life. We're sort of like the radiation is sort of like the fire department. You know, whenever a fire flares up, we go over there and try to take that fire out. It's not really drug therapy or systemic treatment, but still, because the radiation is relatively well tolerated and it has a high probability of controlling the metastasis, an alternative way to manage metastatic disease, again, trying to keep it controlled and keep patients at a relatively good quality of life. And so I think we've done that for a lot of metastatic chordoma patients, is just kind of zap them as it becomes an issue.
How would one choose between that option, for example, and systemic therapy? Is there a rubric that, or a set of principles that patients could apply?
Josh, I was just going to say something in regards to what you're saying. It's really important to evaluate the extent of metastases. Some people may have one, some people may have many, and that will affect that very much. It's been actually shown in several cancers that aggressive treatment of a solitary metastasis can actually make a difference, because we have no way of knowing whether this is the only one or not, and sometimes that's all it is. So treating that aggressively is probably more appropriate. When somebody has many, we really don't have that option, and that's when I think, rather than trying to look for focal therapy, or we still do when it's symptomatic and we have to treat the symptoms, that's when systemic therapy is certainly appropriate, or at least consideration for it.
No, I would agree. I think that's a very good point. If you've had surgery or radiation, it's been many, many, many years, and there's one new tumor that shows up in your lung. That's the perfect place to do surgery or ablation or radiation. But if it's, look, you just had radiation or surgery, and then the tumor came right back, very rapidly, or it came to some other place and you took it out and it came right back. To go back in again and do more surgery and more radiation, that's not the right place, I would think. That would be sort of the place where you say, well, it looks like things have spread and we've tried taking it out by surgery or radiation. It still keeps coming back. This would be the opportunity to really try to understand what's happening. And that would be the point where I think, these genomic tests really become very critical. So you do sort of genomic studies at that point. And if there is something that is really targetable, we find like a switch that we can easily turn off, then we say, okay, this is where we head. But even after, sometimes, like even after doing a very extensive search, it turns up nothing. So in those sort of situations, I have frequently treated patients, sort of blindly, or as I call a shotgun approach, where I use certain drugs that sort of hit multiple very critical pathways in cancer biology itself, and that seems to do the trick as well. So really, I don't think there is a sort of a one-size-fits-all answer. I mean, I think each patient's unique, and you need to take the whole history of the whole thing from beginning to at that present moment, what's really happening.
Dr. Gounder, you mentioned genomic analysis of the tumor. There are a number of different types of analyses that people hear about or that may be available. Maybe some are different here at Sloan Kettering versus other places. There's commercially available tests. What do you recommend if a patient is not being treated here, for example? What should they be asking for?
Yeah, so I think there are multiple commercial tests that are available to do these studies. I think the most experience we've had in a commercial testing is Foundation Medicine. This is a company that's based in Boston, and they have two different tests. One is called Foundation 1, and another one called Foundation Heme. I think the Foundation Heme test is a very, very good test. So there's certain glaring differences between the Sloan Kettering test versus the other commercial tests, which is that only here, I think really compared to any other test in the world, is that we also take a small amount of the blood and then do the sequencing in the blood, and if there are similarities between the tumor and the blood, we subtract that out. So in other words, whatever is noise, all the noise gets subtracted out. So whatever information you get here is pure information. That's exactly what's happening in the tumor. And many others, including Foundation Medicine, you get what's in the tumor, and then you also get noise, but you can't tell which is noise and what is the real signal. So sometimes you grapple with those things as well. But among the tests, and I think there are multiple companies that are racing to do this, because this is no, in the future, or like in a very, very near future, this is not some sexy test that you're going to be doing. This is going to be as simple as a blood test that people are going to do, because the costs are just dropping every few months. The cost is rapidly coming down. So I think among the numerous companies that are racing to do these tests, I think currently I would say Foundation is probably doing a very, very good quality test.
Currently, probably Memorial is doing good quality test, but because we do the normal and tumor. But we are looking at cancer-associated genes of a certain number. So when we don't know really the genomics of the specific tumor, you really don't know what you're going after when you take a group of cancer genes and testing for it. And that's one of the reasons when we do this analysis, we may not find something, but we don't know if we are targeting the right genes yet, because we haven't understood the biology of the tumor yet. So we do lung cancer. Now we know exactly what to look for in lung cancer. So we know they have mutations in certain genes which can be targeted. So we can include those genes in your panel. But when we look at sarcomas and chordomas, we actually don't know what is really the driving genetic factor or gene in those tumors. So we actually use what we have and what we know, what Foundation Medicine uses or what we use, but it is in a way still a blind test for these tumors. So that's why our results may not give us what we want to see, because we haven't found a driver yet. So that happens in the laboratory where research occurs, and they find the driver, and then you know exactly what to look for, and then you can do whatever test, immediately you know what you're looking for. So we are still in an experimental phase with tumors like chordoma, but yes, at least with what we have, we'll keep doing, and maybe we'll find something soon to say, okay, now this is a good driver for this tumor, and now we can start looking for it in our patients. So we are still in that phase of, in a way I should say, learning in these. So.
Thank you. So there's so many questions still to ask, and unfortunately we're running out of time, but I do want to give the audience a chance to ask a few questions. So if people do have questions, now would be a great time. Again, if I could ask just everyone to limit themselves to one question, so we have an opportunity for a number of people to ask questions. So, Irith.
Hi. I want to thank you all for this ongoing effort to help people all across the world, and the union that Josh and the Chordoma Foundation has made is very incredible and very much appreciated by everybody, even people who are not here to thank you all. So I thank you all. And my question is having to do with metastasis. So from my understanding is the en bloc resection is the same principle in my theory that I understood as the complications of biopsying, because once you biopsy a tumor, it's not en bloc anymore. It's been disturbed. I've seen through my studies of patients I've stayed in contact with where when tumors were not resected completely or something like that, they mutate and become more aggressive. It's something that I know there's very few studies on because it's so rare. And on the same subject, I was wondering also if you guys had any surgical seeding procedures where perhaps you can try to avoid that through instrumentation changing while you're changing the position of surgery or such things, because a lot of metastasis is showing up through the group, and that's what I was curious about.
Again, the thing on I think the benefits of, you need to know how to do a biopsy, and we always would recommend excising the biopsy tract with it, which you do on block with the tumor. It's the same principle. The other thing is that, the other thing I'd say, and I'm talking about below the base of the skull now, with sophisticated radiation therapy now, we can control, you can kill microscopic disease, and if there is a problem with a needle biopsy tract, that's very well taken care of. It's a long, long time since I've seen a tract where the tumor grew. And the thing about long metastases, sure, if you have a solitary metastasis, it's worth taking it out, and you get a cure. Certainly, to extrapolate again from sarcoma, chordoma is a sarcoma. We regard it as a sarcoma. There's people who have resectable metastases in sarcomas have about 25-30% cure rate if it's resectable and it's not anywhere else. You know, you have to check everywhere. But it's the same principle in doing the surgery in the lung as it is wherever else it is, the primary is. You just treat it as another primary. Is that?
So, Todd?
Yeah, actually, it's ironic that she brought up part of her question, which has been my question for many, many years now. And that is, there's a lot of talk about chordoma being a very slow-growing tumor. And what there isn't really any talk about, and perhaps because it's only me, but I would assume other people have this experience, is that when it's slow-growing as a primary tumor, and then you go in with surgery and you attack it, what was not known to me or explained to me while I was waiting for proton therapy was that it would grow back nearly 3 times as fast once it was attacked the first time. And so by the time I went for proton, it was already the size that it was growing my entire life in a span of about 3 months. And this actually happened again after the proton wore off 7 years later, and it was slowly growing, and the safe bet was to remove it. But sure enough, once it was attacked, within a span of 8 months, it had grown back 3 times as fast. And I don't hear much education or knowledge about why such a slow-growing tumor, when simply operated on, comes back with a vengeance sometimes. And I'm wondering if there's any sort of knowledge around that fact, and if there's anything that you guys are doing to mitigate it or protect patients from it, or anything to enlighten people who have had that experience.
Let me just, before, I should go down the other end of the table, but I think that when you, certainly in my experience, when I've seen late metastases and you can't control them, I think that the tumor has, the fact that it metastasized or manifested itself, like Dr. Sen said, you can have a huge one, it's gone, and then many years later you get a metastasis in your lung. Well, that means it had to have been there always. It had to have been there from the time you had the original tumor. Something happens. We see this in breast cancer. 20 years later, people get, and the breast is, there's no disease, and then you get bone metastases. That has been lying there for 20 years. Some switch, genetic switch has occurred. I don't know what it is, but and it's the nature of the thing, I think. But sure, maybe manipulating it might do something to the growth factors and that, but I don't think we know that. I seem to think that something happens, again at the molecular level, that makes them suddenly grow again, and that it's just so happens, yeah, you take it out, but this is already, this switch, this genetic switch has happened. But I wouldn't, I'd never knock anything that, opening something to the air is bad. We always hear that, you opened it to the air. I've given up. When I was younger, I would say that's nonsense, but I don't say anything is nonsense anymore. So, but what about the pathology?
I think when the tumor is taken out, Dr. Boland is right. We don't receive the tumor like we look at it and say, oh yeah, I can see the chordoma. That's not how we receive it. We receive it intact with some normal structure around it. So there is no disturbance, at least for our visual eye, when they take the tumor out. But tumors are heterogeneous, and they have clones and subclones, and some of them may have the signature to go elsewhere in the body or recur at the same site. And as we have discussed, even if you take the tumor out completely, there could be microscopic disease, and it's possible those microscopic disease have clones which are capable of, as you say, come back with a vengeance, or at least divide faster to repopulate themselves at the same site. And which clones do that, what kind of signature they have, we really don't know. And that's the fact with breast cancer. They travel from early on to the bone marrow and just stay there for 20 years, and then something happens in the patient's environment, immune system, and then it metastasizes. So I think this is a fact for all tumors. They have that capability. And so it is not to do with the surgery, because you still have to take it out. But there could be many clones there which have a behavior worse than the primary, the so-called, I can say, wild type, the primary clone of the tumor. That could be the reason.
So I want to be respectful of all the speakers. They've signed up to be here until 5:30, and we're rapidly approaching that. So I think we can take 2 more questions, maybe Bernie and then one more over here.
Chordoma is obviously a relatively rare tumor, and many people, both physicians, radiologists, etc., have never seen one. The most common diagnosis when you have an MRI done is that it's a non-functioning pituitary adenoma. I'm talking about clival-based tumors. With today's radiological techniques, can you make the differential diagnosis between that and a chordoma today?
I would say almost 100%. Nothing is 100% in life, but this is as close. You can differentiate a pituitary tumor from a chordoma. They have very different signals.
But is that done nationwide or in centers?
Well, I think that's I think an excellent question. I think you have to have a trained neuroradiologist or a bone radiologist, because these are all bone tumors, and that they have to be able to distinguish that. And you're right, there are certain places where a general radiologist will read the MRI of the brain, and they may not be able to tell the difference. That is, I think that probably goes to a more basic question, is that should every radiologist have that basic training? But it's not possible, because a radiologist is trained to look at everything from head to foot. Just like we surgeons, some of us focus on certain very specific diseases and specific areas, and we look at it in a different eye. It is not that somebody is negligent, but it's just that the education may be lacking in that. So a question, if it is raised, a patient should always be educated to seek another opinion, not to just wait for one opinion. Send the scans out. In this day and age, very easy to get MRI scans. You don't get radiated, unless, of course, your managed care is stopping you from getting one. Number 2 is, as soon as you get the scans, have them send it to some place where they have expertise, and tertiary centers where they can really look at it and tell you what it is. And it never hurts getting another opinion. And that's where I think you have a questionable diagnosis and it's not clear, or at the least you can do is get a follow-up MRI scan in 6 months to see if something is changing or if something doesn't fit. So have multiple eyes look at it, multiple minds think about it. And if you are at a remote place in the country where this is likely to happen, although I would say that it has happened in New York City also, I've seen, so it's not an across-the-board rule, but get opinions.
Thank you. All right, final question here.
All right, first, I appreciate you guys being here, and this kind of goes with what you're saying. I mean, just from listening to you guys, it sounds like you have different opinions, and you're all doctors from one hospital. How, as patients, as we go around to get those different opinions, how are we supposed to decide what the best treatment is if everybody has a different opinion? And I mean, none of us have medical degrees, and we don't know what to do, and we're coming to you guys, yet everybody, it just seems like there's so many different opinions on whether or not we get radiation, not get radiation, get a biopsy, not get a biopsy. Well, I mean, what do we do?
Well, you know, that's true. I saw somebody on Thursday with a big tumor in their leg, sarcoma, and they've been, were in Miami, they were in Massachusetts General, and they got opposite. They didn't get the same advice at all, and they come here as kind of a tiebreaker. I mean, it's, and they didn't tell me they had been to the other places, and then they said, well, that's what the doctor in Boston said, but you know, we don't know all the answers, and nobody does. Nobody knows 100%. There's certain things we do know that you should do, but when it comes to whether you should have radiation therapy and what the absolute indications for it are, and that's why we're all here, and we have meetings every so often. We have a meeting every Thursday that we discuss these, and we differ, but we try to come up with what you have to give. What I think is very important to give to the patient is say, look, this is my best opinion, and this has worked for me in the past. That's all you can say, and it's 1, 2, 3, and the literature would support me. It's going to be like that for many, many, many years, I think. But we're getting closer to accepting that, you know, it's a multidisciplinary chordoma has to be dealt with by all sorts of, radiation therapists, surgeons, medical oncologists. Everybody has to be involved in it. And I think you get a consensus. And I don't think they're wrong, you know, that necessarily, like the case I had last week, neither was wrong. It's just to put the patient, you know, it gets very confusing for the person.
It's very
probably doesn't make a difference in the end, you know.
You know, in something like breast cancer, where there are, you know, there's data on hundreds and thousands of women, you know, it's still there's less confusion, right? But even in a field like that, where there's so much data, there's still controversy in should you do surgery first, should you do chemotherapy first, and so even in a field where there is so much, an overwhelming amount of data, there's still, you'll find multiple opinions, you know. So in a rare disease like chordoma, where we are still learning, we're just sort of touching the tip of the iceberg, I think this is going to be a moving target. It's going to be many, many, many years before we really learn what is the best thing to do.
Yeah, I think the key is to get informed opinions. And so you really, for a disease like this, you need to go to a place where they have expertise in chordoma. I think that's really the most important thing to do. The secondary issue is the differences of opinion. And the way I look at differences of opinion in management of a rare disease like chordoma is that if you get the best possible information and they're not quite concordant, it probably means that there's probably more than one right answer. And that's okay. You know, we don't know the answer to every nuance, but as long as you go to a center that I think has extensive experience in chordoma, even if the opinions differ, they're probably still very good opinions.
Thank you.
Well, with that, I want to thank all the panelists.